full screen is visible?
Yes, it is.
Yeah.
Yes, sir, it is visible.
So thank you, Chhattisgarh Academy of Pediatrics, especially my friend Dr. Kiran Makhija, Dr. Arun Agarwala, Dr. Ashok Mehta, Dr. Mutwani, and of course, Dr. Anup Verma. And greetings to my co-speakers, esteemed friends, Dr. Anand Kesavan, Dr. Simi, and all others in the platform. I will highlight on some pneumonia mimics. See, pneumonia is one of the commonest presentation that we have not only in the inpatients but in the outpatients also. But there are some situations where we have to be very cautious to diagnose it as pneumonia. So this is just a case-based discussion. I will just show few cases on pneumonia mimics. So let us start. I hope the second slide is visible.
Yes, it
Yes.
is
Yeah,
visible.
fine.
Yeah.
So this is a 2-year-old girl who came with fever, cough and cold for 2 days. And there were similar episodes previously also. On examination, the child was wheezing and the routine blood count was 6,800 WBC with neutrophil 44, and you can see the X-ray. Now the point is, whether it's a pneumonia, you can see there is diffuse haziness, especially the right heart border is obscured, whether it's a bronchiolitis or an episodic viral wheeze. Now, few points that go against pneumonia. One is acute onset of cough and cold, which is not very common with pneumonia. Previous episodes, then wheeze, not common with pneumonia, and you can see the WBC count is also not raised. So with this history and features, this clinical diagnosis is an episodic viral wheeze, and the child responded very well. So we should not always go by the X-ray, rather the history, clinical examination, and routine blood count is often essential. Another child, 7-year-old boy, was admitted in intensive care unit with acute distress, but there was no fever. The child is again known asthmatic, was nebulized. You can see hemoglobin was 11, WBC 19,500, neutrophil 70, and there were fluffy shadows in the X-ray. Now, again, by clinical examination and by excluding other causes, it came out to be hyperreactive airway disease, and this leukocytosis is mainly stress-induced rather than an infection, because infective causes were ruled out, and this is a case of hyperactive airway disease and not a pneumonia. A 7-year-old known asthmatic presented with fever and cough. You can see right-sided pneumonitis is there. Total count 13,800, neutrophil 50, and on the right lateral you can see the major fissure is bored up and the minor fissure is depressed. So there is a triangular opacity, a shadow in the chest X-ray. It shows collapse, consolidation, or atelectasis. Now, again, we have to think twice. We have to see the history. Well, there was fever, cough, WBC was within normal range. So is it a pulmonary sequestration? Is it a collapse consolidation? Is it a bronchiectasis, or it's an eventration of diaphragm with pneumonia? So the DD were this, but this is a collapse consolidation typically, as you can see in the lateral X-ray. But when we go to the history, it's a known asthmatic, and an asthmatic may present with this feature, which is right middle lobe syndrome. And this was the right middle lobe syndrome. You can see the major fissure and the minor fissure, that in between there is a collapse consolidation. That's the middle lobe. And it is relatively common in children with asthma. It's a chronic or recurrent right middle of atelectasis rather than acute. And the chest X-ray I have already explained. So the proper control of asthma will help in limiting this case, and not only antibiotics. So asthma control is essential. 6-year-old, known asthmatic, sudden onset respiratory distress with mild fever. And this was the X-ray on 1st February. You can see there is an opacity in the left upper zone. Now the patch disappeared within 24 hours. On 2nd February, you can see there is no opacity. So what was this? This was a mucus plug. Again, very common in asthmatics. So in the first X-ray, the mucus plug was obstructing the left upper lobe, and in the second X-ray on the next day, the mucus plug has dislodged. 8-year-old girl, fever, cough for 10 days. Initially was on cepodoxime, then changed to comoxiclab by GP for 7 days, but the cough was persisting. In this hospital, WBC was repeated, which was 21,000, mainly lymphocytic, 72. Piperacillin tazobactam was started, and this was the chest X-ray. You can see there's a fluffy shadow. Both the hard borders are obscured, a diffuse opacity you can see. So what could be the cause? Is it a tuberculosis? Is it a pertussis, mycoplasma, or any other granulomatous disease? Now, if we examine the child carefully, this was the conjunctiva. So there was no second thought about pertussis. And you can see there was the WBC count raised with mainly lymphocytic, acute onset cough with fever, and this typical X-ray. Now, why not mycoplasma? See, in pertussis, the patchy opacities obscure the heart borders, and it produces a shaggy heart appearance. Whereas in mycoplasma, it's an airspace pneumonia, where the right middle lobe infection is the most common. And you can see this, the X-ray on the right is a mycoplasma pneumonia, where the heart borders are not that obscured. So this distinguishes between pertussis and mycoplasma. So this is another way when we can be sure about the diagnosis and proceed likewise with investigation and treatment. 8-year-old boy was treated for right basal pneumonia, now back with fever, cough, and also not gaining weight. Hemoglobin was 9, WBC 11,000, neutrophil 48. And here there is right basal pneumonia again. And the tuberculin skin test was 12, sputum CBNAT was sent. Now, is this suggestive of tuberculosis? With this, TST12, X-ray, right basal pneumonia, WBC 11,000, is it a tuberculosis? Well, there are certain telltale features of tuberculosis, X-ray finding, which are suggestive of tuberculosis. And those are hilar lymph node. You can see the X-ray to the left. There is clear hilar lymph node. Fibrocavitary lesion. The next X-ray, you can see the middle one, the fibrocavitary lesion, and the right one are the miliary shadow. So only if we have hilar lymph node, fibrocavitary lesion, or miliary shadow, it definitely points towards tuberculosis. Basal pneumonia and or round pneumonia, these are not suggestive of tuberculosis. If there are other features, then we have to go and rule out tuberculosis. So we have to investigate for other causes of basal pneumonia. 4-year-old girl, recurrent pneumonia, failure to thrive, bulky stools, and there is history of salt craving and dehydration in hot weather also. On examination, clubbing was present, and with this feature, the child has already received one course of anti-tubercular therapy outside. And even the child was on asthma treatment. And the respiratory secretion done after admission showed Pseudomonas by culture. And there is a family history of sibling death in early neonatal period with not passing stool. So many features are suggestive. And these were the serial X-ray. The first episode, pneumonia, the second episode, the third episode, the fourth episode. Now, why a child should suffer from so many pneumonias, recover, then again suffer? So these are the questions. Another child, 6-year-old, stunted, treated for recurrent pneumonia, fever, cough 15 days. This child also received ATT a year ago, and you can see the patchy radio opaque shadows. Now, these are the cases of cystic fibrosis. When there is recurrence, when there is history of salt craving, when there is history of passing bulky stool, a sibling death due to not passage of stool, all these points towards cystic fibrosis. And you can see these are the typical city features that we can get in a cystic fibrosis, like the honeycomb appearance, the tram track appearance, the alveoli scattered with mucus filled. These are the typical features. Then we have to go for diagnosis and confirmation of cystic fibrosis. So when to suspect? Chronic, moist, productive cough, episodes of severe pneumonia, particularly with incomplete resolution, recurrent pneumonia, asthma not responding to therapy, persistent unexplained physical signs or chest X-ray abnormalities, and respiratory symptoms with any clinical features of primary ciliary dyskinesia or immunodeficiency. So here we must think of cystic fibrosis and not only go and continue treating pneumonia. A 5-month-old infant, mild fever, running nose. There were conducted sounds in the chest, hemoglobin normal, WBC normal. The shadow was suggestive and reported to be right upper zone pneumonia. So the outside, the child has received antibiotic for 5 days. Repeat chest X-ray, the shadow persists. Now in a 5-month-old child, 5-month-old baby with such a typical shadow in the X-ray right-sided, it is the cell sign, or it is the so it is not a case of non-resolving pneumonia. Chest X-ray or CT, these are usually not required. USG chest, well, sometimes the lateral X-ray or USG chest may help in diagnosis, but there is no question about this is a thymus. A lateral X-ray was done and it was a thymus. So this is a typical thymic shadow, and the child need not be treated with antibiotics at all. 10-year-old boy, recurrent pneumonia, repeated bouts of high-grade fever and recurrent pneumonia on the left side, a particular side, the left side. And each time the child responded to antibiotics, and you can see the retrocardiac shadow in the PA view also. What are the possibilities? It could be a sequestration. It could be a CGAP, diaphragmatic hernia, or a collapse consolidation. So we need to investigate further because there was recurrence. But this was a sequestration, which was proved by CT chest and angiography. As you can see, this is the aorta and this is the blood supply, the anomalous blood supply. That is the pulmonary sequestration. Is a mass of abnormal, non-functioning pulmonary tissue, no communication with tracheobronchial tree, and receives blood from an anomalous systemic artery, usually in the left lower lung. And if it's intralobar, then recurrent infection is common. That what we got, and this has to be removed surgically, otherwise the pneumonia will recur. 18-month-old girl, moderate fever, recurrent cough since 8 months age, treated with several antibiotics, responded each time but recurred. Clinical examination normal, CBCS are normal, TST negative. You can see there is opacity in the X-ray, but on investigation, on CT scan and barium swallow, it was bronchogenic cyst. So when a pneumonia is not responding, we have to think beyond. We have to think also of congenital anomalies. A 5-month-old baby, 3.8 kg birth weight, 3.8 kg present weight, birth weight 2.5 kg. This is third episode of cough and breathlessness. Hemoglobin 11, WBC 11,000. Ventilated for a week at birth for severe respiratory distress. There was sepsis, candida infection also. Disproportionately high pulmonary hypertension on 2D echo. And this was the X-ray. You can see opacity of the left lung. And there is well-defined hyperlucent lesion with septation, atelectasis of the left lower lobe on lateral X-ray. There is bulla, pneumatocyl, and all that, and CT scan was done. So sorry. So this was not a pneumonia, and this was a CGAP. Chest X-ray, PA view, you can see dense radiopacities with breakdown, and this was a CGAP or CPAM. It's a developmental anomaly, and surgical treatment is the only answer. No point in going on treating pneumonia. 11-month-old baby, 3 episodes of pneumonia on presentation, afebrile, no distressed, left lower zone a bit hazy. There was, again, mark the points, 3 episodes of radiological pneumonia, but afebrile, no distress. There was left lower zone haziness. Now, can you believe what it was? It was ectopic left kidney that was producing a shadow which was resembling a pneumonia. So it was the ectopic left kidney. 2-year-old boy, respiratory distress, and this was the chest X-ray. Tracheal and mediastinal shift was there marked, and there is air fluid shadow is also there. And USG chest revealed it was a left-sided eventration of diaphragm. Another 5-year-old boy, sudden onset respiratory distress, complaint of chest pain and dysphagia, complete atelectasis of left lung with mediastinal shift, as you can see in the chest X-ray. But on bronchoscopy, it revealed popcorn. So after the popcorns were removed, you can see the chest X-ray total resolution of the out of the opacity of the left lung that we had on the previous day. So unless and until the foreign body is removed, this will not resolve. So this was a case of foreign body. Another very important history, sometimes we have to check. It's an infant, 1 year, respiratory distress. You can see the chest X-ray. Diffuse opacity, patchy, more or less all over the lung fields, bilateral, increased density radiating from the hilum mainly. This was intranasal application of oil daily and blowing the nose. So this was a lipoid pneumonia. 13-year-old girl, dense radio opacity left lower zone. We should not treat this only as pneumonia because this was a loculated pleural effusion where USG can be a good diagnostic tool to differentiate between a consolidation and a effusion. So if the effusion is not drained, this opacity will not go. So this is not a pneumonia, but a pleural effusion. A dense, rounded, radio-opaque shadow in a 6-year-old boy in the left upper zone. The margin is well delineated. Gradually, the child developed both lower limb weakness. Initially, this X-ray looked like a round pneumonia, and round pneumonia may be due to any organism like strepto, staph, H. influenza, and others. But this child developed left limb, lower limb weakness and upper motor neuron type of paralysis. So this was not just a simple pneumonia. This was a space occupying lesion in the left upper lobe. On lateral X-ray, you can see it's a posterior mediastinal neurogenic tumor. It's a neuroblastoma. So this is not a pneumonia. 10-month-old baby afebrile presents with acute respiratory distress. There is costal hyperostosis in CAFE's disease that you can see. It's often thickened. You can see the costal, ribs are thickened. So this is a CAFE's disease, often present with respiratory distress, and the child may present with incessant cry. So no point in treating with antibiotics. The child needs analgesics. A 49-day-old baby girl, poor feeding, refusal to suck, and excessive lethargy for 2 days. 49-day, excessive lethargy, not passing urine, distress over the last 12 hours. So obviously, the clinical thought was whether it's a probable sepsis. Now you can see there was tachypnea, saturation was low in room air, capillary field was prolonged, chest bilateral air entry was good, but there were bronchi, there was grunting, retraction, liver was just palpable, femoral pulses were weak, no murmur. So the child looks like sepsis. And you can see the X-ray. It's completely white out lung, looks like an ARDS. So cefotaxime was started, catheter was put, but urine was very little. Sepsis screen sent, hemoglobin, CBG was done, pH was 7. And you can see the level of acidosis in the CBG. So what was it? Now, after 1 hour, the saturation was falling. There was altered respiratory pattern. So the baby had to be intubated and ventilated. The baby was stable on ventilator, but the sepsis screen proved out to be negative. CRP was negative. WBC count was only 16,000. So can it be sepsis at this point of time? We definitely had to look for other causes. Now the baby continued to deteriorate, BP falling, poor perfusion, decreased pulse volume. So furosemide, dobutamine all started to stabilize. Then echo was done. It was dilated left atrium, left ventricle. Severe systolic dysfunction with ejection fraction 20% and only moderate MR. What could be the cause? So other investigations were done and ECG revealed the diagnosis. You can see the deep Q waves. So this is Al Kappa, anomalous origin of left coronary artery for pulmonary artery. So unless and until this is treated, the child will succumb very soon. So this needs very urgent treatment. 5-year-old girl fevered with cough for 2 weeks. On day 5 of fever, oral coamoxiclav given, not responded, fever continued. Admitted to a local hospital On day 8 of fever, hemoglobin 10, WBC 20, 3000, mainly neutrophilic, CRP 151. And this was the X-ray you can see. So ceftriaxone vancomycin started, not responded after 4 days. Repeat blood report similar. Chest X-ray repeated similar. No AFB on gastric lavage. USG also not much significant for diagnostic purposes. Fever continued, so antibiotic upgraded to meropenem and vancomycin. Now, with all investigation, the CT chest was also done, and you can see there is diffuse patchy opacity with fibrosis also in the CT chest. Now, at this point of time, the parents revealed, they thought inconsequential, these findings. They revealed that the child used to have intermittent painful nodular skin lesions over both the legs for 3 months. And once they have taken this photograph also long back, and then they shared this photograph. This was the nodular skin lesion, and there were 2 episodes of blood-streaked sputum during this total duration of illness. So can we link something, the skin lesion and the chest finding and the CT chest? So the points to ponder: high-grade fever not responding to broad-spectrum antibiotics, worsening respiratory status, 2 episodes of hemoptysis with skin lesion, raised inflammatory markers. Is it a non-infectious fever which is affecting both lung and skin? So all the test was done. ANA negative, Pianka Sianka negative, bronchoscopy normal anatomy, even BAL microscopy was mixed inflammatory cells, culture no growth, but skin biopsy was suggestive of vasculitis. So deep dermis blood vessels show neutrophilic infiltrates and nuclear debris, and that clinched the diagnosis. This was ANCA negative, small vessel systemic vasculitis presenting as pneumonia initially, then came to the diagnosis. A 3.5-year-old boy, high-grade fever for 8 days, right ear discharge, pain and swelling in right knee, 3 days, severe pain and restriction of movement. Septic arthritis is the common thought. Past episode, admitted in hospitals 3 times in past 6 months, diagnosed as septic arthritis, treated with antibiotics, and also had episodes of pneumonia at 1 year, 9 months, and then again 2 year, 1 month of age. And the second one was query cavity, was treated outside. When admitted, hemoglobin was low, WBC 19,000, platelet was more than 5 lakhs, CRP was high, ANA was negative. But when immunoglobulin was done, all were low. All the immunoglobulins were low. So this was a primary B-cell immunodeficiency with presenting with as septic arthritis. This is actually X-linked gamma globulinemia. So past episodes of pneumonia were misleading, so to say. So if we see as a totality, the pneumonia mimics, the characteristic that can have mimics, one is clinical, that I have shown few cases. Radiological are the most common because pneumonia is more often, well, as per WHO, as per protocol, it's a clinical diagnosis. But of course, a radiological confirmation is often required. So there may be radiological mimics and there may be laboratory mimics also. And broadly, the common causes of pneumonia mimics, one is unusual infections and the second is non-infectious. So we have to be very careful, and to avoid antibiotic abuse, we need to rule out pneumonia mimics if the pneumonia is presenting with some unusual features and not behaving like true pneumonia. So the important step to avoid antibiotic misuse is diagnosing pneumonia mimics. So our mind is like a parachute. It works only when it's open. So we must keep our mind open to distinguish between pneumonia and mimics. Thank you. Thank you very much.
Thank you very much, Dr. Chaudhary. It was an excellent presentation with utmost clarity. And it was very enlightening to know that even a kidney can come and cast a shadow over the lung. And that is most important. If the things are not fitting in your thought process, then unless you have got an open-minded thinking, we cannot think beyond the normal. So it is very important to be clinically very correct. History should be very correct. And we should be more elaborate when the things are not going the way we wanted it to. So it was an excellent talk. Arun, can we have some questions or we will have it at the end of the session?
Sound come karo.
Session.
So we'll
I
have
think
it in
first-
the end of the session.
Yeah, that is good. So over to you, Arun, for the next session.
सर आपको ही करना है
अरे नरेश है ना?
Yeah, yeah.
हाँ, नहीं।
Naresh is there.
Yeah, that was
That was
really
an understanding
wonderful
between me and Naresh.
case-based discussion, sir. It was
Yeah.
really
Yes, sir.
interesting. Especially, I like that X-ray differentiating the pertussis from mycoplasma. It was really nice
It was
X-rays
very good.
also. So, on behalf, I'd like to thank CGAP for giving me this opportunity to be the chairing this session, especially Anup Verma sir, Makija sir, Arun Agarwala sir, and my regards to all the faculty, Arora sir, Chaudhary sir, and Bhaskar Shinoy sir, and all the dignitaries of the Central IAP and CGAP. So moving on to the next session will be complicated pneumonia by Dr. Bhaskar Shinoy sir. So we all know that whenever a child doesn't respond to our treatment of pneumonia, so one of the important considerations will be whether there is a complication of pneumonia. So to give more insights into this topic, Dr. Bhaskar Shinoy sir will be dealing this. He is MD FRCPCS from UK, and he's also got diploma in pediatric infectious disease and fellowship in PID also. Currently, sir is HOD pediatrics and also the chief of pediatric infectious disease division, Manipal Hospital, Bangalore. And sir has been the honorary secretary for the Pediatric Infectious Disease Association for 22-23, and he is the chairperson elect for 24 for PIDA. And he is the joint secretary for Indian Society of Kawasaki Disease. Sir has been the editor for many journals like Pediatric Infectious Disease Journal and Karnataka Pediatric Journal. He's got various publications, national and international journals. And he's also been the editor for various books, especially on infection control, grand routes. And he's also the editor for textbook of pediatric infectious diseases. And he's got many orations to his credit. And he's also the recipient of the Bill Melinda Gates Travel Award in 2023. So I welcome Dr. Bhaskar Sinha sir for his talk. Thank you.
Thank you, team Chhattisgarh. Thank you, Chairperson sir, and Anup and Kiran sir, and all the whole team for giving us an opportunity to be here today. Hope I am audible. Yeah.
Yes, sir.
Yeah. So I am asked to talk about the complicated pneumonia. Of course, Jaideep has nicely told about the mimics. So I'm going to the other part, that is complicated pneumonia. So we know that pneumonia is one of the most common important cause of mortality and morbidity, killing thousands of children each day. And about 16% of the under 5 deaths, it is due to pneumonia. And most of the children are they are below 2 years. And what accounts for this high mortality? It is one of the reasons is severe pneumonia and the complications associated with these pneumonias. So we should know, we should think of severe pneumonia and the complicated pneumonia. These are the two things which are very important. Now let us see what would be the symptoms and signs of children, in children with the severe pneumonia. So one is in infants, it will be a fever, respiratory rate of more than 70, and then distress with the moderate to severe recession, and all the features like nasal flare, grunt, apnea. They can have cyanosis, poor feeding. All this may not be there at once, but at various stages, and as the disease progresses, one and the other symptoms or signs will come. Capillary refill time extended, and saturation is less than 92. And in older children, in addition to these things, the respiratory rate can be above 50, and they are not able to speak also. The nasal flaring, grunting, cyanosis, and dehydration may be there. What are the complications? When I talk about the complicated pneumonia, what are the complications of pneumonia? So it can be divided into pulmonary and extrapulmonary. When you think of pulmonary, it is parapneumonic effusion. You can have empyema, necrotizing pneumonia, sometimes pneumotocele. And these are very common. And sometimes lung abscess, pneumothorax, embolism, ARDS can occur. And with the advent of appropriate antibiotic, the lung abscess and other things have come down drastically. Extrapulmonary complications, they can be pericardial, there may be a dissemination of the infection or SIADH. Let us look at the proportion of complications. This particular paper says the retrospective analysis of about 144 children with complicated pneumonia, and 51% were aged between 1 and 4. The gist of this particular work is that 40% of them are parapneumonic effusion, 40% are empyema, and about 20% are necrotizing pneumonias. And in 42% of the total cases, they could identify some of the etiological agents like Streptococcus pneumoniae or group A Streptococcus. Then how do we recognize the complicated pneumonia is the next question. The complicated pneumonia, we are bothered because it runs an unpredictable course and the deterioration is very fast despite sometimes with appropriate treatment. And even when you come to the diagnosis, the etiology can be uncertain. The diagnosis sometimes can be misleading, and we don't know which way should I go. Should I go for surgery? Should I go for other means of treatment? Then is the etiology of pneumonia, the severe or complicated pneumonia, different from community-acquired pneumonia or otherwise? If you look at the pneumonias, most of the times it is the same, but Streptococcus pneumonia in all the age groups, it takes the upper hand. That is the #1 common organism. In a very young children, newborns, 1 to 3 months, the chlamydia viruses can be causes, whereas in the less than 5 years, 1 to 5 years, it again RSV becomes an important factor, and more than 5 years, of course, in addition to the Streptococcus pneumonia and viruses, it's the mycoplasma. So let us talk about some cases, discuss about cases. A 3-year-old child with the high spiking fever of 7 days, chest and abdominal pain, fast breathing, and difficulty in feeding. The child was sick looking, febrile, with a respiratory rate of 60, with a saturation of 90 in room air. The growth and development appropriate height and weight were okay. Significant indrawings with the decreased air entry in the right mammary and infrascapular areas. That means it's a rapidly progressing pneumonia. Now let us look at what are the pulmonary, extrapulmonary, pleural. In this child, let us see the X-ray. Then decide, do you have an extrapulmonary feature, a pulmonary complication, or something else? So let us look at whether there is a pulmonary complication. Yes, there is a pulmonary complication. Pleura, definitely it is involved. Extrapulmonary, we don't know because we have to do a general physical examination and look at the presence of extrapulmonary complications. Now, what are the possibilities? You have seen that X-ray and costophrenic and cardiophrenic angles are obliterated. So is it a parapneumonic effusion? Is it empyema? How do you assess? Then there are various modalities. One of the most important and most easy in the clinical practice is the ultrasound. We may go for CT, and sometimes we may tap it and to see a microbiological diagnosis. Ultrasound plays a major role in these cases. Now it has become one of the important tools to evaluate the pleural complications. It may predict the development of complications with the early recognition. It is said that it is more sensitive than chest radiography in detecting the small effusions, fibrin septations, or it sometimes differentiates pleural effusions from the consolidated lung. And it also helps you in guiding the insertion of the pleural catheters. And the ultrasound picture, if you can see, the picture A, it shows the uniform ecodensity. The fluid is anechoic, whereas the B, it shows complex loculated effusion with the debris. You can see the multiple debris which are showing. So this is how they recognize ultrasoundically. And this is another clear picture wherein the air bronchograms suggestive of pneumonias. And in the ultrasonography, you can see the small uh, small pockets of pus. So how do you I mean, how do you proceed in such cases? Will you tap the fluid? We can even tap and insert an underwater drainage system, or leave it alone with the antibiotics, or should we take a surgical opinion? These are the few things that we generally think. So when you look at the pleural fluid on imaging, we should try to differentiate whether it is a synomenic effusion or it is a empyema. And what is the quantity? They can even quantify the amount of fluids roughly. And is it a small effusion or a large? Then your decision comes, should I leave it alone, or ICD should be inserted, or VATS should be done, or should I use the fibrinolytic therapy? And mind you, these patients can move from one category to other within no time. So your rapid assessment and rapid starting of treatment is more important. You keep repeating the clinical evaluation, and as and when radiological investigations are needed. A fluid which is less than a pH of less than 7 with a high count with the LDH of more than 1000 and a sugar of less than 40 with a protein of 4 or more, definitely it shows exudate, I mean than a transudate. So this indicates a bacterial infection, though we are not able to find out the microbiological cause most of the times. It might indicate a bacterial pathology. This patient continues to run high fever after 48 hours of drainage and antibiotics. Now, how will I approach this case? Should I continue the antibiotics and wait for some time? Should I change or upgrade the antibiotic? Should I repeat the imaging? So when the CT chest was done, you can see the collections here, the effusions pockets. So now you know that there is some effusion which can be empyema or a parapneumonic effusion. So what are the guidelines? If you look at the IDSA guideline, I have the Infectious Disease Society of America guidelines, if you can see, it clearly defines how to go ahead. When a effusion is small, which is less than 10 millimeter on lateral decubitus radiography, and opacifies less than 1/4 of the hemothorax, then we need not go for any tube drainaging or VATS. Whereas if the fluid, the size of the effusion is more than 10 millimeter rim of the fluid, then again, if there is no respiratory compromise, you need not do anything. But if there is a respiratory compromise, or if the fluid is consistent with the empyema, you have to go for invasive methods. And if it is large, there is no question. Definitely, we may have to go. Large means which opacifies more than half of the hemithorax. So what are the indications for admission? So one of them is the age. A child who is very young, or who is toxic, or there is a respiratory distress like cyanosis, grunting, respiratory difficulty, flaring, all those things. A child who is dehydrated and has a poor feeding, and a child who is immunocompromised, and your routine antibiotics are not responding. So these are the indications. And when you think that the requirement of PaO2 increases, or the need for mechanical ventilation is there, or chest X-ray shows extensive opacities, or if the child is hypotensive, or there is a requirement for vasopressin. That is the need for IC. So how do you treat these cases? So do you need the decortication? So appropriate antibiotic is the most important thing. Additionally, sometimes we may have to do chest thoracoscopy or thoracocentesis. We may have to go for VATS. In rare cases, untreated cases, or which have come late, we may go for decortication. Luckily, the number of decortications are much less nowadays, because most of the centers, there is availability of VATS, which is making a drastic change in the management of these children. Fibrinolytics also, many of them are using either streptokinase or urokinase. 20 to 50,000 units retained there for 2 to 4 hours for 3 to 4 days. to a tube has shown that there is a drastic improvement in most of the cases without surgery. So what are the antibiotics used in a severe or complicated pneumonia? If you think that the organism Streptococcus pneumoniae is susceptible, then amoxicillin you can use. In intermittent resistant or those who are resistant to the penicillins, in addition to ceftriaxone, you can use something like linezolid, and some in Staph aureus you can use cloxacillin or cefazolin, vancomycin, and in a MRSA, which is a community acquired, you can vanco or clinda, or in a healthcare facility acquired, hospital acquired, you may have to use vancomycin. So what is the duration of treatment of these patients? So community acquired pneumonia, if it is uncomplicated, of course, it's 5 days is nowadays the duration of the treatment in a community acquired pneumonia, it is coming down. So it is 5 days at least. But a very severe pneumonia, which is uncomplicated, it is 1 week. But if it is a complicated, you may have to give for at least 1 to 2 weeks. And if it's staph pneumonia, especially if it is complicated, 4 to 6 weeks. So the duration of treatment depends on what is the severity, what is the extent, what is the presence of complications in these patients. As I told, VATS versus fibrinolysis, always it is there. Some of the papers have demonstrated that fibrinolysis also does an equal job, especially when there are no multiple the septations, etc. So this is the summary of the empyema. The risk factors are younger age and varicella, and a clinical feature of fever, chest pain, severe pneumonia, poor response to antibiotics can be there. Investigations we have already discussed. Let us go to the next case. 2-year-old toddler with high spiking fever and a fast breathing and difficulty in feeding. He is sick looking, febrile with the tachypnea, respiratory rate 60, SpO2 686. Capillary filling time increased. There are significant respiratory distress. This is the X-ray. You can see again the claustrophrenic angles are obliterated. Ultrasound was done, a thoracotomy tube was inserted, and parapneumonic effusion with pleural fluid, and that grew Streptococcus pneumonia. Child was started with the appropriate antibiotics. And despite this antibiotic, even after 4 days, the child started continuing with the high fever spikes, retractions. Child became more sick. What should we do now? Should I continue the same antibiotic? Should I escalate the antibiotic? Or should I do some ultrasound to see whether a collection of fluid is there more, or CT? So a CT was done. You can see here areas of necrosis. You can see cavity-like thing in both the things. Here it is very small, but here it is very clearly visible, which is little more. So this is a case of necrotic pneumonia or necrotizing pneumonia. So necrotizing pneumonia is more, you can suspect clinically, but it is a CT diagnosis when a significant portion of consolidated lung shows diffuse or patchy low attenuation and no enhancement even after intravenous context. So it occurs infrequently in children. Probably in the long back, we have missed many of such children who might have developed lung abscess or something like that. So because we didn't have access to CT much, some maybe 20, 30 years back. But now with the availability of CT, it is recognized and diagnosed more frequently. And so that we can start the treatment early and the complications can be reduced. If not treated properly, they can lead to complications like bronchopleural fistula, empyema, respiratory failure, and septic shock. So to prevent these things, it is our duty to have, we should be sensitized about the necrotizing pneumonia, because early recognition and appropriate early treatment is more important in preventing these dreaded complications. So is it due to the same organism? Is the organism is different? This is the usual question asked. So Staph aureus is the most common agent. then Streptococcus pneumonia also can be one of the other reasons. So if it is staph or Staphylococcus, it is a MRSA or MSSA, which produces what is called as a PBL strain. And in the pneumococcus, the type 3 and 19A are known to produce such complications more frequently. So if it is a MRSA, they will have a rapid progression, and usually it can follow influenza, then necrosis, cavity, empyema can be there. They can develop shock or a dissemination. Now, what are the conditions other than these things which predisposes to pneumonia? The necrotizing pneumonia, those who are having congenital anomalies in the lung, they can have those who are bronchiectasis, immunodeficient children, those who have underlying neurological, or those who are infected with the PBL producing organisms, as I discussed. So the treatment can be IV antibiotics initially, later can be shifted to oral. Not initially, at least you should have IV only till the child is stabilized. Supportive care, drainage, and sometimes surgery. The other complication is pneumothorax. The secondary pneumothorax occurs in the presence of underlying lung disease. And this necrotizing pneumonia, especially due to Staph aureus, is one of the most important etiological agents. This is how the pneumothorax looks like. And the pneumothorax, we need to have adequate ventilation, thoracoscopy with a tube drainage, then underwater drainage. ARDS is a other complication. Sometimes we see, and especially a child who is rapidly progressing, a child who is not responding well, a child who goes to shock. And these children will generally present like pneumonia with the shock. They have severe hypoxemia, which is refractory to oxygen, bilateral radiological anomalies, and they need specialized care in the ICU. There are some other rarer complication, though once in a while we may see it's a pulmonary embolism. And mycoplasma infection is known to cause these pulmonary embolisms, especially you can see the CT. So the mechanism is that when Mycoplasma pneumonia infects, antibodies are generated and then immune complexes are formed that induces leukocytes to migrate to pulmonary artery and release large number of inflammatory mediators and lysosomal enzymes. That leads to injury to the vascular endothelium, and that results in the pulmonary embolism. SIDH also occurs in some of the cases, and it is one series. It was said that 1/3 of the hospitalized children with the community-acquired pneumonia can have SIDH. It is dilutional hyponatremia will be there. They can have seizures and confusion. And the most important management, in addition to the treatment of pneumonia and infection, is the fluid management. Hematological issues can sometimes cause like DIC, septicemia, hemophagocytosis occurring in some children, HUS occurring, emboli, and infarcts occurring in some of the cases. So to conclude, the key message that I wanted to give is that high index of suspicion is needed for diagnosis of these complicated pneumonias. X-ray chest, ultrasound, CT, along with the thoracocentesis, and now we have VATS, which can be more important in diagnosis and therapy also. Multiloculated empyema is treated with thrombolytics or thoracoscopy in addition to antibiotics and tube drainage. Due to poor facilities for culture, the problem is that most of the times when we are not doing bronchoscopy or chest drainage, we don't get any fluid, and upper respiratory tract sample is not a true indicator of the lower respiratory infections or pneumonia. So we have to try to get a microbiological sample and do the culture so that we can hit the target. Delay in seeking medical opinion and indiscriminate use of antibiotics. So that's why it is very difficult to identify the isolate the microorganisms in most of the situation. Recovery and long-term outcome is good with appropriate treatment. So thank you for the opportunity. Thank you for the patient listening. Thank one and all.
That was a really wonderful case discussion, sir. and all the beautiful X-rays and images from CT. And you have covered all the points very well comprehensively, along with evidence-based guidelines. That was really very nice. And the question and answers will be at the end of the session. So thank you once again and congratulations for a lucid presentation, sir. Now over to Ashok Mehta, sir, for conducting the last session.
Thanks, Naresh. Sir, it was a very elaborate presentation and a lot of insights into the complicated pneumonia. Now I invite Dr. K.K. Arora, sir, for his talk. And enteric fever is something which even from a servant at home to the super specialist treat similarly, but nobody knows how to diagnose. Where do we have to go? And enteric fever is something which is very much talked about, and almost every physician and clinician is confused कि विडाल करने का है कि कल्चर करने का है, कल्चर करने का है कि रैपिड एंटीजन करने का है. Lot of complications are there. So we have with us Dr. K.K. Arora sir from Indore. He is a professor at the Medical College of Indore, and he has been in many module preparation. He has been involved, and he is an active member of pediatric infectious disease chapter. And without much ado, I will hand over the mic to Dr. Arora sir for his presentation.
Good evening. Am I audible?
Yes, sir.
So, what I am going to talk is about enteric fever. Do we need to relook the way we are managing it? We are all managing enteric fever day and night, but are we managing the way we should have been? So this is a very simple thing. I am just trying to give you some highlights that what we ought to do and what we often forget when we even diagnose or treat an enteric fever. So enteric fever, what we will be just seeing here in this session is about introduction of the topic, how we clinically recognize the condition, what investigations that we are doing, and what management approach we are following. So in diagnosis of enteric fever, the one of the most important thing is an history. A good history will many times will clinch the diagnosis itself because it has got very typical clinical features, and from history and clinical features or examinations, routine investigations give quite much clues. So a CBC is a good guide, but what is important and what is a gold standard is a blood culture. And the main idea of keeping this topic is to sensitize each and every one of us to go for blood cultures. Even we have got nowadays got number of tests, even rapid test, antigen detection, antibody detection, time tested, old Vidal we are doing. But is our approach appropriate? This we are to see. Say, let's take a clinical case. A 11-year-old female male was admitted with fever from 12 days with vomiting and poor appetite. So here is a child who has got fever for 12 days, a fever bit already prolonged. And on examination, he was toxic, febrile, and had moderate hepatosplenomegaly. Now the clinical picture gives us an idea of a probable enteric fever. The CBC, the hemoglobin was 9.4, the total count was 5,300, which 53% polymorphs, 54% lymphocytes, no eosinophil, and 3 of monocytes. Again, the platelets were 1.2 and malarial parasite was negative. He received cefixime for 4 days and a provisional diagnosis of enteric.
Sir, kindly share your slides, sir.
My slides are not visible? Just a Are they visible now?
हाँ अब विजिबल हुआ या
Okay.
Make it full
फुल स्क्रीन कर लीजिए फुल स्क्रीन.
Okay. So
नहीं फुल स्क्रीन
looking at this
नहीं हुआ.
scenario, how to establish the diagnosis. So generally, if we see here, the CBC, especially here the count is normal. Of course, there is a clue that the eosinophils are absent. Even the platelet counts are bit low. But is this picture suggestive of enteric? Cannot say, because the same thing, of course, presence of eosinopenia is a feature, but low platelet could be there even in malaria, low platelet could be there even in scrub typhus, even in enteric fever, even in viral, say like dengue also. So when we talk of clues which we derive from CBC, in cases of enteric fever, CBC could be normal or could be low. There could be leukopenia. But leukocytosis, if we get, that is unlikely in enteric fever. Of course, eosinopenia is present in 70 to 80% of the cases. So is a clinical clue. Platelet counts may be normal to begin with, but they fall in during second week. And most of the times when we see patient during first week, the platelet count may be normal. So prevalence of thrombocytopenia is only in 10 to 15%. So we cannot give too much stress to presence of thrombocytopenia. But of course, eosinopenia with normal or low count in a patient, in a CBC, in a patient of enteric is bit suggestive, is a clue for enteric fever. Now, blood culture is always a gold standard. Why it is a gold standard? Why we should practice blood culture? Because in 80 to 90% of the patients, it will be positive during first week. In 75%, it will be positive even during second week, and in 60%, it is positive even during third week. So beyond third week also, till subsidence of fever, it will be positive in as much as 25% patients. But what is the limiting factor? Why not 100%? The limiting factor is sometimes because of early initiation of an antibiotic treatment and at times inadequate sample size. So it is very important to have adequate sample size, not to start antibiotics, say on day 1, day 2, day 3, give some time to develop the typical symptoms. So when we are taking blood culture for infants and toddlers, the volume should be at least 2 to 4 ml. And for children and adolescents, 10 ml of volume is recommended. Even it is seen that if you are missing, if you have got a case of PUO, where you are not able, the blood cultures are negative, even the sensitivity with the bone marrow culture is as high as 80 to 95%, even in late stages also, even when treated with antibiotics. So it's the message here is one should always go for a blood culture to diagnose enteric fever. Now, as I told you in very beginning, and we are very well conversant that we have got a good number of serological tests also. So do they have real any role? So let's see this small case. A 10-year-old came with high fever for 5 days with abdominal pain and some diarrhea. Now this.
Excuse me, sir. Sir, please, sir, slides are not moving actually, and it is not full screen. So kindly stop sharing and then again start sharing, sir.
Okay.
Yes, it is now the next slide is there, but make it full screen, sir.
Okay. Is it okay now?
नो नो अभी भी फुल स्क्रीन में नहीं है.
तो स्लाइड शो मोड में जाना पड़ेगा.
Slide show में ही है सर ये.
हम लोग को नहीं
बंद
दिख रहा है.
करके
सर आपको ना फुल स्क्रीन पहले से ही करके रखना पड़ेगा.
एक बार
After
बंद
that,
करके
you stop sharing करिए सर सबसे।
first stop sharing. Okay. Now
आप इसको फुल स्क्रीन कर लीजिए सर फर्स्ट स्लाइड को।
स्क्रीन शेयर करूँ ना पहले तो।
आपका सर लैपटॉप में जो स्लाइड प्रेजेंटेशन है उसको फुल स्क्रीन पहले से कर लीजिए।
ओके एक मिनट। इसको फुल स्क्रीन में तो देन आई एम नॉट सीइंग द अदर स्क्रीन।
उसको सर मिनिमाइज कर लीजिए सर। सबसे नीचे में सर जूम आपको दिखेगा सर, जूम प्लेटफॉर्म का।
जस्ट नाउ आर दे बीइंग शेयर्ड नाउ?
तो शेयर तो हो रहा है
हो रहा है।
बट स्क्रीन नहीं है सर। एनीवे सर इसको आप मूव करके देखिए सर, मूव हो रहा है तो वो पता लग जाएगा।
हो रहा है मूव?
नहीं नहीं
एक मिनट। इस पे मैसेज आ रहा है योर स्क्रीन शेयरिंग इज पॉज्ड।
स्टॉप करके सर फिर स्टार्ट कीजिए।
Yeah. Is it sharing now?
Yes sir, and full screen is there sir now.
right
Yes, sir. This is good.
It's fine.
Sir, kindly see that it is moving or not sir.
Yeah.
Yes sir, it is moving also sir.
Okay, right. So a 10-year-old came with high-grade fever for 5 days with abdominal pain and some diarrhea. His WBC count was 5,600 with 70% of polymorphs, 1.8 lakhs platelets, MP was negative, and a typhi.m was positive. So what will be the next step? A, enough evidence to start antibiotics as the typhi.m, which tells us about the IgM. Or would you like to send blood cultures and start antibiotics? Or send Vidal and blood culture both? So what should be done in such a case? So as we know that typhi.m, which tells us about IgG and IgM, and typhi.m especially talks about IgM, and when there is an IgM is positive, that is probably suggestive of an recent infection. But it is not necessary that a typhi.m, if it is positive, this will surely going to give us the diagnosis of enteric fever. Because now many laboratories are offering typhi.m, and people are getting typhi.m during first week, second day, third day, fourth day, diagnosing with typhi.m and starting treatment. Of course, if the picture is suggestive of probable entry, one can start treatment after sending blood culture and can start antibiotics. But what happens that typhi.m is not very specific test and hence does not nail the diagnosis. This should be made very clear in our minds that it is not 100% test, but if typhi.m is negative, it is more informative that it is not entering. But if it is positive, it is not gives us diagnosis that it is enteric only. Of course, it gives us suspicion. So if there is clinically suspect, send a blood culture for confirmation and start antimicrobial treatment. We should do this way. And Vidal has no meaning since it is less than 7 days. So this is another thing which we should always keep in mind. And many a times our clinical friends, what they do when the patient arrives, the fever is only for 4, 5, 6 days and Vidal is being said. So value of Vidal before 7 days, before 7 days, it is not advocated. So even when you are going for an typhi dot also, it is not a diagnostic test. It could be just an supportive test. Rather, why my suggestion is even why to go for typhi dot also. Go for the gold standard. If you are suspecting enteric fever, 3, 4, 5 days have already passed, go for a blood culture rather than going for even typhi dot also. Even other tests like typhi rapid immunochromatographic test, a good number of tests are there, but according to Cochrane database systemic reviews 2017, diagnostic accuracy of above test is not clear and it needs robust evaluations. So unless these tests are being evaluated, we should not give too much reliance to these tests. Further, should we consider Vidal as a diagnostic test? Because we all have a habit of doing Vidal and we are using Vidal from last so many years. But again, according to Cochrane Database Systemic Review 2017, WHO recommends only blood culture as gold standard. Although Vidal detects agglutinating antibodies against O and H antigens, but they have poor sensitivity, specificity, and predictive value varies in geographical areas. In different geographical areas, there are different. So even for India, what should be the most appropriate levels which we should consider as positive Vidal? It's not very clear. There was a big study from Amritsar, which they suggested that any levels above 1:160 should be considered as positive. But again, this Vidal test, when we are doing, it should be done after 7 days. It's better if there are serial Vidal being done. So even it gives, if there was a previous infection, then it gives amnestic reaction. Even in Vidal, the cross reactivity with non-salmonella organisms like malaria, dengue, brucellosis, etc. is there in enteric fever endemic areas. So it is the Vidal again should not be used as a test to diagnose, but it can, of course, if there is a strong clinical suspicion and say blood culture is not coming positive, and if the Vidal levels are very high, then they should be taken as an evidence, but not on the basis of Vidal, we should start treating a patient as an enteric fever. So in tropical environment, any fever which is more than 5 days with spleen palpable, consider enteric fever. So clinical clue of a fever beyond 5 days, palpable spleen with presence of normal or low TLC with eosinopenia, again there is a possibility. Blood culture, of course, is a gold standard. RDTs have more negative predictive value, as I told before also. Even if you are going for a typhi dot, and if it is negative in first week, it is indicative that it is not entering. But a positive typhi dot is not suggestive of entering. And a single titer of Vidal should be interpreted wisely. Of course, PCR is now an emerging modality in diagnosis. So when the PCR becomes cheaper, and then of course, definitely it will be a very good test to diagnose enteric fever rapidly. So this is about the diagnosis. So whenever we are diagnosing enteric fever, we are to be very cautious, say especially interpreting Vidal, interpreting typhidot, going for a blood culture. Now, what choice of empiric therapy? So because many a times typhoid is a clinical diagnosis also. So what empirical therapy for typhoid fever should we go? It depends on the condition of the patient. If we got an indoor patient, so if the illness is severe, if there are any complications, then we should go for IV treatment. And IV treatment, the first line choice is ceftriaxone, ceftriaxone, and ceftriaxone. And second line choice is, of course, cefotaxime if there is a concurrent hepatitis, or Astronam if there is an penicillin allergy. But first line is nowadays for children, especially, is only ceftriaxone. And when we are treating the patient on an outdoor basis, we should use cefixime as a first line choice, and azithromycin again can be used as second line, but only in case of penicillin allergy. Otherwise, our standard therapy for enteric fever for all practical purposes is ceftriaxone as first line for indoor patients and cefixime as first line for outdoor patients. So the drugs, when we are using, the ceftriaxone should be used in a doses of 100 milligram per kg per day, and the maximum dose should not exceed 4 grams. Say, many times you got very obese children, maybe a 80 kg old child. So that doesn't mean that we should calculate it by 100 milligram per kg per day. The upper limit, dose limit is 4 grams for ceftriaxone, 8 grams for cefotaxime. When we are using cefixime orally, it is 1.2 gram for cefixime upper limit, and 20 milligram per kg per day. Even for azithromycin, again 1 gram is the upper limit, and for Astronams again 8 grams is the upper limit. So the duration, as far as once we have started treating enteric fever, how long we are to treat? Again, the duration is very important. We are to treat at least 7 days after defervescence, or a total of 14 days, whichever is later. Sometimes, as we know, in defervescence in enteric fever could be as late as 9, 10, 11 days. So suppose if the defervescence occurs on, say, 10th day, then we are to treat it for 17 days. So we are to treat for 7 days after defervescence. And if suppose azithromycin is being used, it is to be given only for 7 days. Now, what is the role of steroid in enteric fever? So steroids are indicated only in severe illness when there is a toxemia of typhoid. If the patient, say, for example, patient with shock, coma, or altered sensorium, then dexamethasone in a dose of 3 milligram per kg followed by 1 milligram every 6 hourly for 2 days may be given. Prolonged use of steroids can increase relapse rate and cause adverse effects, hence should be used judiciously. So again, the steroids have got a very limited role in treatment of enteric fever. Further, if there is a delayed defervescence, if by day 7 the antibiotic defervescence has not occurred, but child looks less toxic, and if there is increase in duration of frequency, even the fever spikes are going down, if there is a quick response to antipyretics, there is no need to change or go for new antibiotic. The same antibiotic can be continued till 10 days because delayed defervescence is known. Further, if there is no defervescence and child looks toxic with increase in fever spikes after 7 days of starting, optimal treatment is a clinical failure. So how to differentiate whether there is delayed effervescence or clinical failure? So in case of clinical failure, the child will keep on looking toxic or will even look more toxic. The fever spikes can be more also. Child is not eating well and the treatment is optimal and there is no response. In such case, we'll take it as clinical failure. And in such case, the most important thing is to rule out complications such as any abscess formation, infection associated hemophagocytic lymphocyte histocytosis HLH. We are to look for co-infections such as malaria or hepatitis A, look for drug fever, look for thrombophlebitis. So if there is enteric fever, so the possibility is that if there is no response in spite of giving treatment, so there could be one of these possibilities. And if we were been treating, if the patient was not culture positive and if the child was culture negative, in that case, we are to a clinical failure can be taken as even mistaken diagnosis, or we are to review the diagnosis again, taking careful history, physical examination, and repeating the investigations. So if patient as a normal standard, we have to use ceftriaxone, which is the drug of choice, even if there is a delayed effervescence, as it prevents unnecessary use of azithromycin, which must be kept as a reserve drug. Why azithromycin should be kept as reserve drug? Number one, that it is a second line anti-TB drug also. We should not waste it as such. And secondly, even the cases are being reported now, even from Pakistan, that there are cases which are now resistant to ceftriaxone. So if we use not unadvisedly, then there are chances that we may develop by using azithromycin or rapidly shifting one drug to other, the antimicrobial chances of developing antimicrobial resistance are high. So even quinolones, which at one time being indicated, and when to start with, after when there was a failure of first line drugs like ampicillin, cotrimazole, and chloramphenicol, then that times quinolones were even used in pediatric patients also, but now they have been largely advised not to use quinolones in pediatric patients for treatment of enteric fever. And aminoglycosides, again, most of the times when we get blood culture reports, which we find that aminoglycosides are, there is a sensitivity for gentamicin and amikacin. So we should avoid using aminoglycoside as their site of action is extracellular, while salmonella is an intracellular organism. So they are not going to help and not going to act. So the main, again, message here is to use the standard therapy. So in this special era of antimicrobial resistance, always ask your lab to provide drug sensitivity. So whenever you are asking for a blood culture, always ask for drug sensitivity reports with MIC, minimum inhibitory concentration, and its interpretation. Most of the times, the older way of giving 1+, 2+ sensitivity is not valid now. We should always ask for MICs and MI with their interpretation. So in enteric fever, the MIC of 1 or less than 1 with ceftriaxone is associated with excellent clinical outcome. If the laboratory reports MIC of less than 1 or equal to 1, that means it is going to give excellent result and clinical outcome. Rising ceftriaxone MICs are being reported from India also as from other countries. Now, MIC breakpoints, say whenever we are talking of MICs, so MIC breakpoint for resistance of ceftriaxone, if we want to see, when we read culture report, we are to see as it has been seen that MIC of 1 or less than 1 is excellent. So when the MIC, the breakpoint for resistance is 2, in case of UCAST, European Committee of Antimicrobial Susceptibility Testing, which European, most of the European countries are using, or it is when it is more than 4 or equal to 4, as in case of clinical and laboratory standard institute, which USA is being using. So whatever our pathology lab is using, whether they are using the CLSI breakpoints or UCAST breakpoint, they should clearly suggest us that what they are using. And if it is more than say 4 in case of CLSI or more than 2 in case of UCAST, then that shows resistance to ceftriaxone. And in those cases, when there is a resistance to ceftriaxone, then in those cases, azithromycin is the drug of choice. So azithromycin should only be used when there is an ceftriaxone resistance. Further, if the child is hemodynamically unstable or severely sick, then meropenem can be used as an alternative. Nowadays, it has been seen that when there is a delayed effervescence, people start using meropenem, saying that it is ceftriaxone resistant. So ceftriaxone resistance should only be concluded from the laboratory reports. It should not be concluded clinically. So the standard treatment, even in India, as some of the cases reported from North India, there are cases which have reported ceftriaxone resistance, but they are very few in number. Most of the patients still, as on date in India, are ceftriaxone sensitive. So a message is, when we are treating enteric fever, the treatment is ceftriaxone when you are doing indoor, and cefixime when you are treating on outdoor basis. Do not cross limits. Do not unnecessarily use meropenem and estozonam, or even for that matter, azithromycin, suspecting resistance on clinical grounds. In present era of antimicrobial resistance, this use of these drugs will make us again, if the resistance really develops, then God only knows what we are going to do. So this is my utmost request to everybody for the same. Thank you very much.
Thank you very much, Arora sir, for an elaborate presentation. When it is enteric, there will be a lot of questions also. Sir, I was a part of a TOT on diagnostic stewardship this year in an executive body meeting. So the message goes there like we should all stop doing a Vidal test. And if at all is to be done, instead of slide test, it should be a tube test. This was what was told at that time. What is the take on that?
I think that even we should not talk of Vidal. The best thing is we should not talk of Vidal. We should take it as an obsolete test, because most of the time what happens, it's mainly the slide test, the rapid test, which is the culprit, because everybody is asking, somebody getting fever for 4, 5, 6 days, asking for an Vidal. The rapid Vidal comes and it is positive most of the times. So, and patients start getting treatment, and most of the time.
Sir, what would be your one-line carry-home message regarding Vidal test in terms of typhoid?
I'll recommend that one should not do Vidal one should go for a blood culture only. Because
Okay.
even if you are suspecting enteric, although you are allowed to treat, you can give antibiotic. No, you send blood culture and start antibiotic. And if the culture is negative and patient improves, you can very well stop it also.
Right.
Because once you have not sent blood culture and suppose you have started based on Vidal, now there is a compulsion to treat for 14 days also.
Yes, definitely. Definitely.
I'll ask to have the opinion of Dr. Bhaskar sir and Jaideep for the same.
Yeah, this is the most controversial thing, sir. एक बार हमको बता दीजिए क्या करना है. So there are still 64% people remaining.
Yeah,
In fact,
I think even Bhaskar sir has even written an article in our that standard guidelines also. He was the
Yeah.
author for Vidal.
Yeah.
So he will be the best person to advise us on this matter.
See,
Yes, sir.
Vidal, as somebody told, it is if at all, it should not be done for in first case. It is not the recommended test, but there are some advantages. Having said that, one is when your tests are negative, the child has come with multiple antibiotics and the culture is negative. It is one of the additional tests, not as the main diagnostic test. Second thing is, as somebody pointed out, it is the tube test which is a little more reliable than the slide test. Third, most of the times the tests are done before 7 days, which should be discouraged. If at all it is done, it should be done 7 days, late after 7 days. Fourth is, if possible, a rising titer is more important than a titer at a given point of time. These are the few things that, but having said that, the standard of gold standard is the culture. There is no other thing. Even if the child is on antibiotics, we have to send a culture, appropriate volume, appropriate method, and then start antibiotics. And with the modern methods of culture technologies and biotech and all, so we can isolate organisms even in those who have been on antibiotics. So that is the take. So don't depend on Vidal only. False positives and false negatives are common.
Thank you, sir. Thank you very much. Sir, one more thing regarding steroids. 3 mg per kg will be 30 milligrams for a 10 kg child.
Point.
Will it not be
3.
complicated?
It must be 0.3.
0.3.
The dose written is 3 per kg followed by
It must
1
be
per
0.3, sir.
Yeah.
Okay. So there is a big correction, no? It's 0.3 mg per kg stat followed by 0.1 mg per kg for 2 days.
Yeah.
Okay. Okay. In the slide, it was 3 milligram per kg. I was a bit taken aback. Because
Correct, correct.
Topographic error.
Naresh, would you like to say something?
Yeah, Ashok Mehta sir, there are a few questions. Can you please take that? Because I logged into another device. I'm not able to see the questions.
Just a minute. I'll see.
Yeah. Tushar sir had asked few questions to Jaideep sir regarding tap, I think. Tap.
I lost that question.
I believe it's regarding the ICD placement.
There was a question, sir, regarding pleural tap. Is it required in effusions?
I think it's
Pleural tap for diagnostic purpose, yes. But for for a routine diagnostic purpose, yes, you have to do a pleural tap. But most often the recommendation is that once you diagnose, then it is better to drain it. So routine, the question is a routine, is it routinely recommended to do aspiration before putting IC? Yeah.
Yes.
So the question is that answer is that you have to confirm it that it is in the place. So it is better to aspirate. That is one thing. Second thing, if you have a ultrasound based guided thing, this may not be necessary. Ultrasound based, you know that you are entering the pleural space. There, it may not be necessary. But for taking culture, taking the sample for testing, it is needed.
Hello.
Yeah.
Good evening, sir. Hello.
Yes,
Hello?
Tushar, ask her. Tushar, boliye.
Yeah, sir. This is regarding aspiration for deciding putting an ICD. Most of the guidelines, like Thoracic Society guidelines, do not routinely recommend aspiration to decide whether we should put an ICD or not. Only in case if we are suspecting that it is not infectious, then only TAP is recommended. This is what most of the pediatric guidelines suggest.
Yeah.
The reason they have given is just to avoid repeated sedation and kind of anesthesias in this. So that's why just I wanted to know,
Yeah,
because this
that's
is
what
common
I told.
practice. This is a common practice, and it is like we are kind of obsessed to decide whether you have very well given indications for putting an ICD. I think if we follow that, there is no need to do a aspiration.
Yeah.
Then
Routinely, it
put
is
a
not
ICD.
required. That's what I told. Routinely, it is not required. And there is one more question: role of intrapleural steroid. I don't think it is needed. No role of steroids, especially when you are thinking of empyema. There is absolutely no role. And other questions, Naresh has asked. 19A strain of pneumococcus is covered in all. See, most of the, except GSK's PCV10, all others are having 19A. They were arguing that, I mean, they why it is not there, because they used to tell that there is a cross protection between 19A and 6A and something like that. But of course, there is evidence of cross protection, but this cross protection doesn't last longer and more sturdier.
Okay, sir.
There is one more question, sir. At peripheral government center where blood culture availability is not there, should we stick to our clinical suspicion through history of more than 5 days fever without any other localizing signs with no significant clinical finding and normal CBC? Then should we go ahead with the treatment for enteric or no?
May I just make a comment here? See, that the clinical typhoid is a well accepted diagnosis. So
Yeah.
sometimes culture may not yield anything, but I totally agree with other speakers that culture should always be sent in a prolonged fever. There is no second thought about it. But starting antibiotic should not be delayed, because we can de-escalate always. There is definite clinical suspicion of typhoid if the febrile child is sick. There is centrally coated tongue, liver is palpable. So these are all clinical corroborative signs. And
Yes.
hematologically, most of the time we find there is leukopenia. So our sick child with leukopenia, with hepatomegaly, eosinophil low count is not always possible. It's not always seen. It's very difficult. If it's present at all, then it's corroborative. Then we are justified in starting antibiotic.
Yes, sir. Also, at the end of the first week, we can always clinically diagnose typhoid. It looks sick. The child is very
Yes.
sick at the end
So-
of the 1 week. We can take
But
action regarding that. No
yes,
issues.
but again, I will totally agree that Vidal should not be relied at all, because it's the rising titer, and we cannot wait for to do a Vidal. We wait for 7 days to see the rising titer. We wait for another 7 days. That's ridiculous. Whereas blood culture we get in 3 to 5 days. So Vidal should never be done, relied upon at all. But if there is rising titer, then we can come to a diagnosis. So,
but even in the smaller places, I feel if there is no facility, I think with the present the scenario, most of the centers will have, even the smaller places will have. Suppose your place doesn't have, make a arrangement to see, talk to the microbiologist or the lab people to see that this facility is there. Blood culture is a must.
Ideally,
Yes.
we should not allow for, say, as a recommendation, we should say that Vidal should not be done. Then and then only people will go towards blood culture, because to get a Vidal even for tube test, it becomes an easier option. And then again, the thing is that people will not wait for 7 days. Again, even the tube test will be done on fourth, fifth day. The problems will keep on being there. So better if we strictly say no to, as we are not recommending say any serological test also, like even the rapid test also not being recommended, then why for Vidal? It's only that we have been using this test for so long that we try to find out some or other way just to continue. Of course, if used judiciously, then again judicious use, judicious interpretation uh, is needed. Then again, if we'll not do it, so then there will be no question. So better if everybody starts asking for blood culture, even at smaller places also the blood culture facility will come. And it's not very rocket science that blood culture is not possible at smaller places. Now, even the PCRs is being done at smaller places, so why not blood cultures?
Yes, that
And
is why we.
we are practicing in such a area that every patient which comes on second day, third day, fourth day, fifth day, they have already received antibiotics.
Yes.
Even the day one antibiotics are started. So what my point is, how antibiotics is going to affect the blood culture, which is very sensitive. Even every patient which is coming, hardly we see that no patient without antibiotic 3 day, 4 day, only taking paracetamol unless a pediatrician is saying. So how to explain this negative culture after taking antibiotics? How to then prove that the patient is really having?
Moreover, Anup sir, all the patient coming from periphery, they are already started on cefixime. A good
There is a
percentage of
very-
pediatricians and the GPs who are working at the periphery, any disease they start with cefixime at 10 mg per kg. Now, subtherapeutic dose for typhoid of cefixime. So, blood culture, what is going to happen to it? We are not very clear about it. So,
Actic culture is not much affected by antibiotics. The currently mostly it's done the bactic. The conventional culture is hardly done. So, it's not affected by antibiotics. So
sir,
should be said.
That's what I
sir,
told.
truth is,
Tech and
बिलासपुर में
other.
अभी भी बैकटेक नहीं होता है सर. बिलासपुर में conventionally होता है, except some corporate hospitals. Backtake is not running because we have not developed a culture for culture. That is the main thing.
No, I think we should start the initiative by talking to the microbiologist and get it done. See that it is there, then only I will send. So you people should be very strict about that. You should have a discussion with the microbiologist. Then it will be. It is not
it is
It is
very
not
important.
that it is not possible. It is possible, but nobody insists. That's why they are also not doing.
Okay.
It was a very fine discussion.
एक last question है sir, how to switch from ceftriaxone to oral antibiotic?
In cases of enteric fever, because it is very difficult to hold the patient for more than 7 days. What Dr. Arora said that we'll have to give continue ceftriaxone after 7 days after defervescence.
No. What we are to treat the patient for 14 days. That is one thing. As long as the patient is not able to take orally, you have to continue ceftriaxone. Once the patient starts taking orally, you can switch to cefixime.
To cefixime.
Yeah, total duration should be 14 days. Not ceftriaxone should be 14 days. Total duration of treatment is minimum 14 days. If there is a delayed defervescence, then the day the defervescence occurs, the fever goes on day 10, then you have to give it for 17 days. If fever goes on 11th day, then you have to give it for 18 days.
Means,
But
means,
minimum for 14 days.
means once it is diagnosed as enteric fever, we diagnose it as an enteric fever, we'll have to give for antibiotics for 2 weeks.
2 weeks, yeah.
Or 7 days after defervescence of fever.
Or seven,
Whichever is
7
Or
days
7
after.
days after deference.
No, whichever is shorter. Sorry.
whichever it is.
Okay, Dr. Arora, excellent talk.
Thank you. Thank you so much.
Thank you. Thank you very much.
Ashok, to conclude.
Thank you very much to all the members, to our esteemed faculties for giving us a very clear message regarding the complicated pneumonias and pneumonia mimics, and enteric fever is always everybody's choice. And now that we are clear that we should be more towards culture, and we should ask our microbiologists to go for backtech so that we get early reports and we can make changes. It was an excellent organization. Dr. Anup sir, Kiran, Arun, and the whole Chhattisgarh Academy of Pediatrics are to be congratulated. And we are very thankful to our esteemed speakers and our guests from outside Chhattisgarh to have taken time for this. And we are very thankful for that. Over to you, Arun.
So Arun is somewhere busy, so I request our treasurer, Dr. Nilay, are you here?
Yes, sir. Yes, sir.
Okay, so Nilay will be communicating for the vote of thanks.
Sir, it has been a wonderful 1 hour, 1.5 hours to listen to all the speakers. And I would like to thank all the speakers on behalf of Chhattisgarh Academy of Pediatrics, and along with our scientific convener, Dr. Anup Verma sir, and Kiran Makhija sir, who is our president. So I think all the talks were excellent, and it has been all these talks were very relevant to our regular practice. So this was the USP of this 1.5 hour. So thank you very much, all the people, all the seniors and colleagues who were present and who listened to the talks. Thank you very much, and
Thank you. Thank you, Dr. Bhaskar. Thank you,
and
Dr.
last-
Arora. Thank you, Dr. Jaideep, for a very impactful presence. Thank you so much.
Thank you
Thanks
all.
to
Thank you for
our-
the opportunity. Thank you for giving us to opportunity to interact with you. Thank you so much.
Thank you. Thank you. Thank you. All the
So
best.
thank you all these dignitaries and our chairperson
Thanks
also.
to Juventus, and especially Yogesh for being a very key person in organizing and very nicely arranging the meetings. Thank you, Yogesh.
Thank you. Good night. Good night.
Thank you.